Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. We're very glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health Systems. Today, Brad and I are broadcasting from our administrative offices, and our guests are Dr. Paul Shetzley, Medical Director of Aultman Inpatient Rehabilitation, and Angie Eaton, Director of Post-Acute Therapy Services at Aultman Woodlawn. Good morning and welcome to our show.
Good morning.
Thank you for having us.
All right. Aultman's comprehensive medical rehabilitation program is a 60-bed intensive inpatient rehab unit. Their specially trained and skilled staff will assist you in recovering from injury or illness. From physicians and nurses to dietitians and social workers, the focus is to restore function and improve the overall quality of life after the illness or injuries you may occur. We'd like to remind our listeners that our program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe to our program.
Okay, welcome to the show, Dr. Shetzley. Please tell our listeners about yourself and your path to becoming the medical director at Aultman Inpatient Rehab.
So it involved quite a few years, but I kind of enjoyed every step along the way. You know, after college, I went to osteopathic medical school in Ohio, and from there trained in physical medicine and rehabilitation in Cleveland at Metro Health Hospital. It really set me up well. I got a lot of great experiences, saw a lot of different patients with a lot of different disabilities, from spinal cord injuries to brain injuries and hip fractures, people that need therapy. And following that, I moved back here to Stark County, joined my partner, and began a physical medicine and rehabilitation practice. Worked at a variety of different hospitals, and about 5 years ago, the opportunity to join Aultman Woodlawn Rehabilitation Hospital became available, and it was really the opportunity of a lifetime for me. And so I'm really happy to be able to become medical director here at Aultman Woodlawn about 5 years ago.
You must have gone to Ohio University.
I did.
My daughter went there. Unfortunately, she did not become a physician.
Oh, yeah.
Okay. What is inpatient rehabilitation?
So, I mean, in essence, it's physician-directed, hospital-based rehabilitation care. It's different from nursing homes. We have physicians involved, but it's team-based. It's a very democratic process. We have, physical, occupational, speech therapies, rehab psychology, rehab nursing, multiple disciplines. We work with our patients, from, every angle possible with everything we have to try to get them to be independent as possible. And our goal is always to get people home.
So where are you located?
We are located at the corner of Woodlawn and Hills and Dales, about 3 or 4 miles from the main Aultman campus. Yeah.
Okay. So welcome to the show, Angie. Tell us about yourself and your position as the Director of Post-Acute Therapy Services at Aultman Woodlawn.
Hi, thanks for having me. I am a very proud mom of 4 amazing kiddos. I am a physical therapist. I have been at Aultman since 2001, and then I came out to Woodlawn when we opened in 2003. I am currently responsible for physical therapy, occupational therapy, and speech therapy for the post-acute division, which includes home care and the inpatient rehab.
That sounds like a lot to be in charge of. So with regard to patient therapy, I know that it takes a lot of time and effort and dedication. So how do you do it, and how do you help people get through it?
So as Dr. Shetzley mentioned, we do 3 hours of therapy here, at least 5 days a week with our patients. And 3 hours of therapy sounds like a lot, but we spread it out throughout the course of a day. Patients can do as short or as long of sessions as they need. And here's the thing, they're not going to the gym and lifting weights and running on a treadmill for 3 hours. We are focused on functional tasks like bathing and dressing, swallowing without choking, communication, patients getting out of bed, getting out of their chair, walking, and going up and down the stairs. So we look at what a person needs to do in their typical day to go home. And then we work on those things here so that we can make sure we can get them safe and strong and get them home with their families safely.
How long do patients stay with you?
Our average stay is about 2 weeks. Some are shorter, some are longer, depending on what the patient and their family need, what kinds of things we need to do training with, what kind of modifications they need to make with their homes, and how we can work with them to get them back.
My understanding about that facility where you are, it's a residency place, correct? As well as therapy and all that sort of stuff,
Well,
correct?
no one lives here. None of the patients live here. They're here for a short-term rehab stay. So they come for our
Okay.
intensive program, and then we work on getting them home or, to the next level of care.
Okay, and so you would take surgery patients from Aultman, is that correct? Or coronary, that kind of stuff?
Yeah, we
And
see all kinds of patients. So we can see patients with neurologic conditions like a stroke, spinal cord injury, brain injury, Parkinson's. We see patients after hip surgery, after back surgery, after an amputation, or patients with cardiac issues or respiratory issues. We've seen a lot of that post-COVID. So we can really take anybody that isn't able to go home directly from the hospital and give them that intensive short stay to get them home.
what we hear in the pharmacies is that Aultman's facility is the place to go. It is very highly regarded, and we hear that all the time.
Thank you. That's good to hear.
So, and that is their first choice. So if they
That's
have a
what we want.
choice, if they have a choice, I don't know, but that's what we always hear. So it's very good. Dr. Schutz, so what can the patient's family be part of the rehab process?
Yeah, that's a good question. Thank you. Yeah, it's a very essential key to the rehab process, and we really try to get families involved from day one. Like I said before, our goal is to get people home. We don't get everybody home, but about 80% do get home, and the family is a integral part of that. We get them involved early with training them on maybe transfer techniques, showing them how to use any of the assistive equipment that our patients might have. We talk to them about home modifications that might need to be done to successfully get people home. We do schedule formal family instructions with families, and we have them involved in our weekly team conference as well too. So we make sure they're on board with everything that's going on from a rehab standpoint as well as a medical standpoint. Yeah, so families very important to the success of our program.
What specialty certifications does Aultman Woodlawn have?
Well, we're CARF certified, and happy to say that we got our maximum number of years following our last CARF survey, and that's the certifying body for rehab facilities. Acute, inpatient, hospital-based rehab facilities, or CARF is kind of the gold standard. And they come in, they kind of leave no stone unturned. They look at everything from facility safety to our equipment to how we're treating our patients with therapy. Do we have all the medical coverage that we need? So CARF is one of our certifications, but then we also got additional stroke certification. We do see quite a few strokes out here, and we have some specially trained nurses, therapists, and physicians with additional stroke expertise as well. So we were able to get additional stroke certification as well.
Okay. How is the staff trained to work with the patients?
They're trained, in a lot of different ways. A lot of our nurses have rehab nurse certifications, which is like added qualification in the rehab nursing specialty to deal with wound issues. We deal with complex wounds oftentimes when people are immobile. We deal with a lot of bracing issues. We involve orthotics and prosthetists. And then obviously we have all of our different specialists, from the physical medicine rehab doctors to the rehab psychologists. We have medical physicians here, as well as cardiology involvement to assist with any complex medical issues as well.
If I could just add, we also have some therapists that are specialized in home safety and home assessment. So we can help the patients prepare their homes, because a lot of times the things that bring them to rehab are life-changing. So they need to make some changes short-term and or long-term at home. So we have some specialists certified in that as well.
Do you go to their home and I guess analyze the situation there?
Yeah, we can do that. We will go out during their stay if it's necessary, take the patient and their family out and do a assessment of the home, almost like a show and tell or a trial run. Get them out there, have them get in their bed, have them get in their bathroom, have them sit in their favorite comfy chair at home and make sure they can do those things, even do the steps to get into the house. Because if they can't do that, they'll never make it home. So we can go out, do that test drive and make all the recommendations that are needed for their homes.
My guess is that you find many homes that just are very difficult to move around in, and particularly two-story, that sort of stuff.
Yeah, fortunately though, in that aspect, there's a lot of options, especially with technology. There's stair lifts, or we can help them make a first floor setup if they need that. So we have our specialists that can help with that aging in place process, that home safety process, and help them get the things they need. But yeah, homes are definitely, we think these big glamorous homes are great until we have a health issue, and then simpler is better.
Wow. Okay. All right.
All right, it's time for our first break.
Yes, sir. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder to stop by the pharmacy and talk to our pharmacist about a Health Matters membership savings program. We want you to stay well and save money.
Okay, we were talking about staff training before the break, and I guess I wanted to kind of ask, I wondered if, can you give a garden variety experience of what it would be like for a patient to enter your facility? I'm guessing maybe you could talk about like the initial visit or the pre-screening process, or just something to help people understand what it might be like. I mean, you're probably going to be coming from the hospital, I assume, but I'm sure there's other things that happen too. Can you talk about that?
Sure, yeah. Basically, it does begin with the pre-screening process at the hospital. We have pre-admission screeners here that receive referrals from a variety of different locations. Obviously, Aultman's our biggest referral source, but we accept patients from every hospital in the surrounding counties. So we evaluate, their diagnosis. Do they have a qualifying diagnosis that kind of resulted in their function being affected? Are there certain things that they're not able to do now that they were able to do before? Like, is their walking affected? Their ability to get dressed or eat? So we look at their function, what we call functional impairments, or just problems with doing what they need to do to be independent in society. But then the other piece then is we have to look if there's any medical needs as well too. Typically, if they're totally medically stable and no medical issues, then sometimes it's more often to get them to qualify to come to acute rehab. But oftentimes, and most times, there are some medical issues that are involved in the patient's case as well too, because we do have physicians seeing them here. So that's part of the rehab process as well. So yeah, so then once they come here, they get evaluated by the rehab physician. A plan gets put in place with the estimated length of stay. We talk about goals, and we involve the family and the patients in this goal setting as well. That's a critical piece of it. We want to find out from them what their hopes and dreams and aspirations and goals and everything is, and we want to help them achieve that and help them function at the highest level of independence that they can. So we set goals and estimate length of stay. And then we work with them every day, at least on average, about 3 hours a day of therapy. And we have a formal team meeting or team conference, which we involve the family and the team to discuss their current status, their plan, any kind of barriers, and just keep, everybody on board and kind of walking in the same direction, so to speak. We do that once a week. Yeah.
Okay. And I don't want to make assumptions, but I think it might be helpful for listeners to know too. I'm assuming that you kind of look at everything. So you probably look at, not only, you mentioned ambulation or how well they can get around, but you probably look at maybe their nutritional needs, or probably ask them about their dietary habits outside of their experience to try to make sure they're being all addressed. Would that be fair too?
Yes, definitely. Yeah, that's a good point. Yeah, we really look at them from holistic. Yeah, from point of view. We do have a nutritionist that evaluates everybody. We look at their protein intake, make sure they're being adequately nourished, making sure they're being well hydrated, or adequately hydrated, because oftentimes they're on modified diets. So we do offer a lot of supplements, protein supplements, and occasionally iron or vitamin supplements as well. But yeah, we really do. We look at them from a holistic standpoint, and other issues too, like their pain management. That's obviously very important. We want them to be able to participate adequately, in therapy. We do skin management and wound care. So yes, it's a pretty holistic, total body, approach.
So how often would a patient see a doctor during their rehab stay?
So the minimum requirement is 3 times a week, but that doesn't include the admission or the discharge or our team staffing notes. So in reality, it works out to 5 or 6 times a week that at least that you would see a physician. So and on most days it's the rehab doctor, and then on the rehab doctor sees, or the medical doctor sees, the patient as well a few times a week as well.
Is there anyone else on the healthcare team that we haven't covered that would work with patients to help them on this journey to get back home?
Yeah, we have respiratory therapy. Sometimes we have patients with tracheostomies, emphysema, COPD, or sleep apnea. So our respiratory therapist is a very important component of our team. We have nurse aides that do activities with our patients, and that's been a great addition as well. We have a wound nurse, a dedicated wound nurse that's really kind of in charge of screening for any kind of pressure ulcers, and then also giving treatment recommendations as well. We also have a neuropsychologist, which is really a great, I think, feather in our cap. It's not often that we have that, a neuropsychologist works at a community rehab hospital, but it's really been a great addition. He'll screen for, depression or anxiety, barriers that may be really affecting their rehab progress, but then also able to assist with like cognitive or memory or thinking evaluations as well too, which can really help direct our speech therapist and our other team members. So that's been a great part of our team as well.
Excellent.
You may have covered it all, but what do patients do when they're not in therapy?
Go ahead, Angie.
Yeah, so we do have time where they're not working with us in therapy, and we'd still try to keep them busy though and engaged. So we have dining rooms on each of the units where patients can go to have a social, interactive dining experience with each other. They tend to make friends there, and then they're cheering each other on during their therapy. So it's a neat thing. We also have an outdoor courtyard area where patients can go to get some fresh air and sunshine. Not so much on days like today, but we do have nice days coming this summer, so they can get outside and enjoy that. We also have weekly activities for our patients to just promote some fun and interaction. And then our rehab nurses will work with our patients in the evenings to help them with their therapy homework. So therapy homework is something that the therapist assigns a functional activity that they want them to carry over outside of therapy to continue their rehabilitative process. So the nurses will work with them on that as well. So we tend to keep them busy. We do incorporate some rest, but and because that's important in recovery too. We want them to stay active and interacting with each other.
I'm not sure about this question, but do most patients get to go home? I would think so, you know?
Yeah, so about 80% of our patients return to the community, meaning they go home. But some do have to go to another facility, depending upon their needs, after they leave us. So, but the plan here is always, plan A is always to get them home.
Interesting. I don't know where that question came from. Can you help the family prepare their home for the patient's return?
Yeah, so we talked a little bit about those home evaluations that we'll take them out and have them assess the environment and assess them for any equipment needs, any additional treatment needs that we might need to address for them to go home. We also like to do a lot of family training, and we want to do that early. We don't want the families to feel like they're drinking out of a fire hydrant, being overwhelmed with all the information. So we wanted to give it to them in spurts throughout the stay. And some of that'll be on site here, and some of it'll be going out to the patient's home to prepare them for that return.
So you would, on someone who's severely debilitated, would you go home with him and her and make sure everything's in order? That they've done, the family members have done what you specified needed to be done.
So we can go out there with them while they're still our patient, go out and test it. Look, make sure that the grab bars that we recommended were installed, that the railing by the stairs that we recommended is there so they can get up the stairs safely, and do those things, work with them and try it before they go. And then when they leave us, we might recommend that they continue with home therapy to continue that process on the next leg of their journey.
Okay. It is time for our second break. You're listening to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. You are listening to Health Matters with the Medicine Center Pharmacy. This morning, we are talking with Dr. Paul Shetzley and Angie Eaton.
All right. Can we talk about insurance and Medicare? What are the options and limitations and hoops that sometimes are a challenge for patients to get the care they need?
So yeah, Medicare is our primary payer. That definitely has a policy of paying for rehab. We do have qualifying diagnoses. 60% of them have to fall into them, and there are things such as, strokes or brain injuries or hip fractures. So Medicare is a good payer for acute rehab. When it comes to managed Medicare or insurance products, we have to typically get pre-approval. So we send the insurance company therapy evaluations and documentation to support a need for inpatient rehab that's physician directed, hospital based. And once we do get an approval, Medicare will give us a target length of stay. Typically, Medicare dictates to some degree how long they stay. We don't have to follow it exactly, but they give us what the target is. So basically, all insurance companies do pay for rehab. We get occasional workers' compensation payment for inpatient rehab. Buckeye or CareSource, Medicaid will pay for inpatient rehab as well.
I don't want to split hairs, but I just wanted to highlight something you said that caught my attention. And you said inpatient rehab. So is my interpretation of inpatient rehab that would be at your Aultman Woodlawn facility, whereas outpatient would probably be in the patient's home? Is that correct?
Yes, yeah, that's a good question. Yeah, we're inpatient, hospital-based acute rehabilitation. There's also inpatient therapy services that occur at skilled nursing facilities in the community as well. And then what you referenced is home health care, and that can be home physical and occupational therapy, or even home speech therapy, or home health aides, home nursing. That can occur in the home. And then the other place where therapy occurs is outpatient therapy centers, and those are scattered throughout the community.
Okay. What happens with a patient after rehab?
So yeah, we it doesn't end, with acute rehab. We hope to jumpstart them and put them in place to succeed in the community, but for the vast majority of our patients, they have more therapy that occurs even after they leave us. Oftentimes, it's home health care, like I mentioned, with home, physical or occupational or speech therapy, occasionally home nursing to assist with, maybe the heart or lung issues or medication issues, or even a home health aide that can assist with bathing. So typically, home care occurs when patients are relatively homebound. They're not supposed to be out, independent in the community and receiving home health care services. So if they are, then it's time to transition to outpatient therapy. And outpatient therapy is a different type of therapy. It's often more higher level strengthening and balance type, therapy. Whereas in the home, we really focus on function, what you need to do to be independent, with regards to caring for yourself and being safely mobile within your home. But yeah, like I said, it doesn't end at the acute rehab hospital. We're just kind of we're the springboard and hopefully set people up for success with equipment needs and getting the family educated and just getting them started on the road to success. But for many of the conditions that we see, such as strokes, I mean, you're going to see recovery occurring over several months. So therapy doesn't end with us. I mean, the initial few weeks are the most critical as far as rehab goes, but it definitely does not end with us. Yeah.
Okay.
And we educate people on independent exercises too. We really want to let them know what they can do for themselves and how their family can help them too with exercises.
Okay. Well, we got a question through our Facebook Messenger that I want to direct at Angie, if you don't mind.
Okay.
And the patient wants to know, what's the difference between occupational therapy and other types of therapy? And I thought that might be a good question for you to touch on, because before I got to do a rotation in my pharmacy school training, I didn't really understand some of the differences. You think therapy, you think, like you said, the gym. So.
No, that's a great question. Thank you for asking. So occupational therapy has a focus on the self-care aspect. So they will work a lot with our patients on bathing, dressing, grooming. They'll help a patient be able to do those tasks that are a little more personal and private. A lot of times families are able to help or more comfortable helping a patient stand up and walk. But when it comes to the bathroom, when it comes to bathing, when it comes to using the toilet, that stuff is a lot more personal. So occupational therapy really focuses on that self-care, on that ability to do those things. They're also super important in the oral care. Oral hygiene is very important. It's a huge risk for infection. It's a quality of life. So they're working with the patients on that, the ability to brush their teeth, to clean their mouth, to prevent pocketing of food that might then choke or aspirate. So they work a lot on those fine specialized self-care items as opposed to physical therapy. We're doing more of the movement, and speech therapy is doing the communication and the cognition and the swallowing. So I hope that answers the question.
It does. And I think, doesn't occupational therapy also include like helping evaluate if the patient can still cook meals and, do things like, things around the house, which I never really thought about until something happens. So
yes. So we actually have in our therapy gym, we have a kitchen area where our patients can come down and do simple meal prep activities. So if they tell us, I make grilled cheese and soup for myself for lunch, we will have them do that and make sure they can do it safely, that they're not going to catch anything on fire in the microwave or burn something on the burner or stick a knife in the toaster, those silly examples. But we want to make sure that if they're going to do a task at home, that they can do it safely. So yes, doing meal prep, doing laundry, doing those things that they need to do, again, to take care of themselves. That's the focus of OT.
I think we forget about all those things until something happens, and then you realize that there's a lot to do.
Absolutely.
My wife had a situation about a year and a half ago where she broke her leg in 3 places and had rods and screws, and it reminded me real quick how much she does for me around the house. So, it's until you have that situation, you realize, whoa, I mean, things just kind of run and you forget all the little things. So
Yes, and that's what we work on here is all the little things, all those functional things. Again, it's not about lifting weights or running on a treadmill. It's about functioning. It's about the activities that you do every day to get through your day, to keep yourself and your loved ones safe and going.
I think we've talked about most of this, but what else do you want listeners to know about Aultman Rehab?
For me, I would say the biggest thing is just that we are here, we are open, we are growing. We have doubled our beds in the last year so we can help more people in our community. And we want the opportunity to do that. So we are definitely here and lively and growing and ready to help people with their rehab needs.
So you've added, I believe they've added on to that facility at least once or twice. Is that correct?
There's been some different, they have built on to the back of our campus, but there's also just been some reallocation of some of our beds to be able to expand our inpatient rehab unit. So we've been able to go from 30 to 60 inpatient rehab beds over the course of the last approximately a year so that we can serve more people in this capacity.
How's your food?
Oh, the food's great.
Okay. You know, I've been in the hospital more than once, and people are always complaining about the hospital food, but I really don't. My occasions at all, but the food's fine. So I guess people just come there with expectations of steak and eggs, and all that kind of stuff, which is not right. Okay.
Well, we have a great food service team here, and we do have that nutritional focus that Dr. Shetsley was talking about. So we try to provide food that does help the patients in their rehab process and fuel their bodies, but also that tastes good to them so that they will eat it too.
Sure. Okay, our last break is here. You listen to Health Matters with the Medicine Centered Pharmacy. Welcome back to Health Matters. I'm pharmacist Paul White, and I thank you for joining us. Let's get back to the last segment of the show.
all right, well, we would love to hear about some patient success stories. I'm sure you both have some.
Yeah. I had heard about this question, and I was thinking there's been so many over the years. I think one that really struck me though was a young man that I met. It's probably been 8 years ago, maybe, who had a dirt bike accident and broke his neck. So he had a spinal cord injury in his neck, and it affected everything from his neck down. So his arms and his legs were both very weak. His whole body was affected by that, and he had been a real active guy, prior to that, very athletic, risk taker, and after it happened, though, his life really kind of unraveled. He lost his relationship, and he developed some skin issues, a lot of pain issues, and he really came to us at a very kind of low state. But we really worked with him, passionately from just many different angles. We had neuropsychology involved. We use a lot of adaptive equipment. We were able to get him up with weight supported equipment, allow him to bear weight through his legs, and just really, got him to be as independent as possible. And it was really interesting too, because you talk to people that have physical disabilities, but you realize they're still the same person, and I really worked to instill that in him, that you've got a different way of getting around now. You're going to be primarily getting around in your wheelchair, but you're just still the same person. If you're enjoying watching a football game with your buddies or eating good food, you're still the same person. And I think you really embrace that. And in the end, it's almost like his quality of life was better than it had ever been. Even though he was primarily in a wheelchair for mobility, he was able to stand for transfers. But he was able to live independently then. And he even started playing wheelchair rugby, which is, so he was able to, restart his athletic career, but from a different point of view. And so that was really, really inspiring for me. And I look back at it, a lot of the things that we did early on, it really set him up for success. We had the equipment we needed, to be able to practice car transfers in our, simulated car transfer machines. We were able to get him the equipment he needed with lightweight wheelchairs. We were able to get him up to bear weight, with our weight supported equipment for walking on the treadmill or even in the hallway. So yeah, that was one that really, really makes me happy when I look back on it.
Wow.
Angie, do you have one?
Yeah, the one that comes to mind for me would be a recent stroke patient that we had here. A younger gentleman, and when he had a very severe stroke, and in the hospital, his wife wasn't even sure if he was going to make it, but they did get him through that difficult phase, got him out here to rehab. And when he first came to us, it took 2 people for us to even get him sitting up and then to work into standing. He was very emotional when he would see his wife. She was here every day working with him, extremely supportive, extremely involved. And she was working with him every day, but sometimes just seeing her and knowing the process, he would cry. He was really, it was a long road. But by the time he spent a couple of weeks here with us, we saw him make those gains to be able to move, to be able to speak, to communicate with us. And then he walked out of here in his jeans, his cowboy boots, and a t-shirt that said something about beating his stroke. So he walked out the front door with his family in his jeans and his cowboy boots to go back to his life with his wife. So it was a very exciting story to see.
Wow. Are stroke individuals the most difficult to deal with in the mental area, or
It can be so variable. Sometimes our brain injury patients can be more challenging because their brain is recovering. So they might have different kinds of behaviors, different kinds of levels of alertness. So really the neurologic patients from that perspective can be more challenging, but honestly, with an older population, we see a lot of people with dementia, and we have to work with that, enter their reality, meet them where they are, and help them to be able to participate in activities that mean something to them. Sometimes when a therapist walks in the room, patients see our navy blue scrubs and they want to hide under the blankets. They want nothing to do with us. So we have to be creative in how we approach them. How do we engage them in something that matters to them, in a meaningful activity to them, and then get them to do the things that they really, in the end, want to do to be able to get better and go back to their life at home.
Dementia, the word dementia didn't exist early in my career as a pharmacist, and I've been around a long time. What did we just call them crazy before, or where were we?
I don't know what we called them before, but I'm glad we have the ability to work with them now. I think we've learned a lot in how to care for these patients. I think we've learned a lot in that, just like we have heart failure or lung failure or kidney failure, these people have a brain failure, and then we have to work with them and still give them quality of life and help them and their families. There's a lot of caregiver burnout in the area of dementia. So we have the opportunity to not only work with that patient, but with the people that are going to be taking care of them to help set them up for where they are now and where that may progress to in the future.
Over the years as a pharmacist, I've had discussions and phone calls with individuals, and I can remember one in particular who called me many, many years ago and said, and we had just sent his prescriptions down to his house, and he was holding them in his hands, and he said, well, you didn't deliver my prescriptions. So I went down a couple blocks from the store, and there he was holding the prescriptions in his hands. And I just thought, okay, this is my first. I mean, that really was my first. It was it was probably 40 years ago. And guy lived right down here on Roslyn, and he was a good customer, but something just happened and it just snapped.
Yeah, we have to meet people where they are and then wrap as many supportive services around them as we can. That's where our social service team is so big, where they can help provide community resources, whether it's financial assistance or different community resources that can come in and help individuals that are struggling, whether it's physically or cognitively that way.
I don't know where we are, Brad. We're pretty close, aren't we?
Yeah, I think it'd be probably best thoughts to, any parting thoughts either one of you'd like to share about your facility and how proud you are of it and what you want to make sure that the public knows before we wrap up.
Yeah. I'd like to just say we have a beautiful campus out here. and welcome anybody to come out and take a look. We have walking paths in our courtyard to practice, walking on different surfaces. So whenever it's nice out, we like to get people, outside. We have a lot of windows to really let the outside come in. And it's just a real kind of positive uplifting environment, really try to help energize people when they're here.
Did Aultman acquire the property right across the street from your facility or not?
Not that I know of.
Yeah, I know
Not
that
that I'm aware of.
some time ago, I think there was some talk about it, but I haven't been out that way for a while, so I didn't notice. The guy across the street, invented the tap opener on a can.
Oh, wow.
True story. Yeah, really
Yeah.
interesting. That was a big, beautiful building across the street. So.
I was thinking back to your comment about dementia. I think part of the issue too is people didn't live as long in the past too. In order to get dementia, they would die of other things, but we provide
the
medical care that advances people's lives.
Sure. Prescription drugs available 50 years ago are nothing like what's available today. So, well, I think we're out of time, aren't we, Brad?
Yep.
Thanks to our guest, Dr. Paul Sheetzel, Angie Eaton of Aultman Inpatient Rehabilitation. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health Systems and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week. We'll see you next Friday right here on News Talk 1480 WHBC. And thank you very much, both of you.